So I just want to welcome everybody to our Reach Out, Reach All webinar. And this is with Professor Mark Edwards. It's part 2. So he will be answering your questions. We are delighted that Professor Mark Edwards has agreed to join us for round 2. And for those of you who don't know, Professor Mark Edwards is a movement disorder specialist of St George's University of London, the Atkinson Morley Regional Neuroscience Centre. That's not at all a mouthful for me. So I think, Mark, if it's all right with you, we are just going to head straight into questions.
Fantastic. Oh, nice to meet everyone virtually, and thanks all for being here. And I'm really looking forward to answering your questions as best I can.
Fabulous. So we'll dive straight in. Last time we spoke, you touched briefly on the causes of dystonia, but can you expand on this a little bit more? What do we know about the causes?
So I think that it's a good question, but it's quite a complicated one because effectively dystonia has many, many different causes. And that's probably must be one of the most difficult or complicated things about having dystonia, is it can be quite difficult to get information because there are lots of causes of dystonia. Lots of things are said about dystonia might not be relevant to you. I think that probably the best way of dividing up causes of dystonia is between isolated dystonia and then other causes of dystonia. So isolated dystonia effectively means that people have dystonia only with or without tremor. But when you look at the brain, so you do a brain scan, the brain scan is normal. There's no particular thing that's triggered the dystonia, like an injury to the brain or another illness. And usually isolated dystonia is not a progressive problem. So it starts, it gets a bit worse over a period of time, and then it stays more or less the same. And so that type of isolated dystonia is the commonest cause of cervical dystonia, of blepharospasm, of what's called Meigs syndrome, where the mouth and eyes are involved. It's a commonest cause of task-specific dystonia, so hand dystonia or dystonia that musicians might get. It's the commonest cause of childhood onset dystonia, and there's some genetic causes of that. So that's isolated dystonia. Then on the other side of things, there are people who have dystonia as part of another disease process. And sometimes that's something which has happened to the brain, like a stroke, or somebody has MS and the inflammation has just hit a particular part of the brain and caused dystonia. Or it might be part of what's usually called a degenerative neurological condition. So something where brain cells are gradually stopping working over time, and people get dystonia, usually as part of lots of other things as well. So for example, people with Parkinson's disease quite commonly also get dystonia. And then there's another part of dystonia which is called functional dystonia. So functional dystonia is part of a condition called functional neurological disorder, which is really a different level of problem. So there's not a problem with the basic wiring in the brain. There's certainly not a problem with people's will or motivation, but people can't get in touch with their body in a normal way, and dystonia can sometimes happen as part of that. So you can see just from that thing that there's lots and lots of different causes of dystonia, which is why it's really, really important to be able to see a neurologist who understands about dystonia and can help you get answers for your particular problem.
Thank you. And I know it's a very broad subject that we could probably do a webinar just on that, but I think that was a really concise way of explaining it. So thank you. We've had the question, when diagnosing dystonia, is the Glute 1 deficiency syndrome considered as a possible cause routinely? And perhaps could I ask you, for those that don't know, to include in your answer what that deficiency is?
So Glute 1 deficiency is a genetic problem where there's a little protein that's like a pump that sits between your central nervous system and your body, and the central nervous system is sort of separated from the body very much, and so things have to be actively transported into it, and this little protein transports glucose from the body into the nervous system, into the central nervous system, and when it's not working properly, you basically don't have enough fuel in the central nervous system. And that's a rare genetic disorder which can cause quite a lot of symptoms and problems, including epilepsy in childhood, but very rarely it can be a cause of dystonia, typically something that's called a paroxysmal dystonia, so the dystonia comes and goes. So the answer to the question is that no, it's not part of a routine assessment for somebody with dystonia, but in a very specific situation where somebody might come and say, I have attacks of dystonia, then it might be part of the workup, or what the neurologist might be thinking about in that situation. And to investigate it, you can do that with a genetic test, or you sometimes do a spinal fluid type test. So that's another good example of a really, really rare condition which can cause dystonia, and that's again why being reviewed by a movement disorder neurologist who might think about those things is important when you're not getting answers for your condition.
Okay, thank you. And do you think that dystonia has been around for generations, but we just didn't have a name for it? Obviously, the awareness is growing at the moment, but it isn't a relatively new condition, right? That's evolved alongside other things, i.e. environmental factors, physical activities in humans, and that kind of thing.
So no, I think dystonia has always been there. It's part of the way the brain can go wrong, and so I don't think there's any reason why it's a new thing. It's obviously just been better recognised, and there isn't a lot of evidence that dystonia is getting more common over time. But obviously, there's a whole issue about how well it was recognised in the past. But yeah, I think it's always been there.
Okay. And is it possible to have more than one form of dystonia at the same time?
It's not common, or it's very, I would say it's very uncommon. I think that part of that might come because people often give particular labels to dystonia in a particular part of the body. So for example, dystonia affecting the eyes is called blepharospasm. Dystonia affecting the neck is called cervical dystonia. But some people who have blepharospasm might at a later date develop problems with their neck turning. And that's really actually part of the same thing. It's just that dystonia has spread a bit to affect another part of the body. But it's very uncommon to have two different causes of dystonia in the same person.
But there is a way of which it can either spread or show up in, is it in body parts that would be, say, the mouth, the jaw, the neck, or would it be completely separate? So the hand and the foot, for instance?
Yeah, it's more common for people to get spread sort of in adjacent body parts. So sort of people who, somebody has blepharospasm getting problems in the neck or around the mouth. But some people, particularly children who might often develop generalized dystonia, it will usually start somewhere, like it might start in the foot, and then gradually over time, people get more problems, and so it spreads further throughout the body. But the cause is still the same.
Right, okay. And leading on from that then, because I think it leads on quite nicely, is Meige syndrome. How is that diagnosed, and then how is it treated?
So Meige syndrome is really just it's a word, or Meige was a neurologist in France in the late 19th century, but it's a name for a particular distribution of isolated dystonia. So in Meige syndrome, typically people would get blepharospasm, they would have oromandibular, so mouth involvement, might have laryngeal involvement, might have voice problems, and might have neck involvement. So it's sort of this combination of symptoms, or sometimes it might just be the blepharospasm and problems around the mouth. So it's an isolated dystonia typically, and so the main treatments are those which are used for isolated dystonia. So it would be typically botulinum toxin probably as a first step in treatment, and then using medication, and then rarely but potentially thinking about deep brain stimulation surgery. The last time we did the seminar, we talked quite a bit about the fact that for most people with dystonia, it's not just the abnormal movements, there's additional problems like pain and the way that it makes people feel, and so on. So those are always an important part of treatment too, but just sticking with the pure medical stuff, it's around botulinum toxin medicines and deep brain stimulation surgery. Botulinum toxin tends to be a relatively good treatment for blepharospasm and for neck dystonia. Doing it for problems with voice or problems around the mouth, it's a much more complicated thing. It requires much more expertise, and there's much more chance of it not working or causing side effects. So treatment of Meige syndrome can be quite difficult for that reason.
Okay, thank you. And could you explain dystonia, sort of, while we're on the subject of different dystonias, if you like? Could you explain dystonia following an anoxic brain injury and what can be done to help?
Yeah, so like I was saying right at the beginning, when the brain is injured, and that can be injured in lots of different ways, including by a loss of oxygen to the brain, which is what a hypoxic brain injury is. So when the brain's injured, sometimes you get dystonia as a result. And that really just depends on which part of the brain's been injured. So post-hypoxic dystonia is a well-recognized thing that happens to some people who've had a period of time of loss of oxygen to the brain. You most commonly see that in children. So cerebral palsy, which is a broad category, but often people who've have cerebral palsy, they've had a problem with oxygen supply around birth, can develop dystonia. But then obviously after birth, you have children and adults, if they have a cardiac arrest or a respiratory arrest or something like that, then that can be a cause. The treatments are, and probably it's a sort of broken record of treatments. The treatments are kind of fairly similar. So often with post-hypoxic dystonia, it's a generalized problem. So botulinum toxin has less of a role to play because you can't give botulinum toxin to all muscles. But still, you might, if there's a particularly problematic thing that might happen, so maybe somebody's arm is very postured and painful, you might treat that. Then you might use medications, and there are a range of different medicines that are used. Obviously, like any medicines, any medicines can have side effects, so that can be a sort of, there's a balance there. And then sometimes deep brain stimulation surgery is used, but deep brain stimulation surgery can be fantastically effective for certain types of dystonia. But when dystonia is caused by brain injury, or when it's caused by brain cell degeneration, it tends to be a lot less effective. So just to give you an example of what that might be, if you take the situation where deep brain stimulation surgery works the best, which is probably in childhood onset genetic dystonia due to this gene called the DYT1 gene, then most people get a 70 to 80% benefit. If you look at people who have got brain injury, who have deep brain stimulation surgery, the benefit might be 10 to 20%. And there's people who don't get any benefit at all within that. So treatment is quite complicated in terms of the choice, and there's not many things to do necessarily. But yeah, that's I think that has Dana disappeared just now?
I do believe she may have dropped off. I do apologise for that. I was busy typing up the questions, so I didn't know. But I have questions here, so I will jump in. So I'll just find our place. So thank you very much for that. Now, actually, moving on to a slightly different kind of topic, moving away from the different types, we've had a question about the role of the movement disorder departments, and once you're referred there, how do they help? So could you perhaps give us a little bit of an overview of how that works in the NHS?
So within the NHS, within neurology services, actually, before I answer that question, I just saw something in the chat which is important about my last question, which I didn't mention, which is about baclofen pumps. So amongst medications, there are a variety of medicines that are used, and there's a medicine which is called baclofen, which can be used as a tablet. For some people with generalized dystonia, particularly when it involves the back, so when people are getting spasms of the back, then that medicine baclofen can be given as an infusion directly into the spinal fluid. And that involves an operation and a tube put into where the spinal fluid is in the lower back. And then there's a pump which is implanted underneath the skin. So I've met a number of people who've had baclofen pumps put in for dystonia, and I think the results are very variable, but there are certainly people within that who've had fantastic benefits. But it's an invasive procedure, and it's something which obviously needs a lot of thinking about, and it's a pump and a bit of hardware in your body, like a deep brain stimulation system is a bit of hardware. So it needs a bit of looking after long term, but it's another treatment option which I missed out. So about
what you've just said about that, to clarify, is that for adults and children? Because I know that's often used in childhood dystonia, but is that across the board?
Yeah, no, it can be used in adults and children. In children, you may have to redo operations because obviously children grow, and you might have to extend the tubing and so on, like you may have to do with a DBS system. But yeah, it's across the board. But it's certainly not a kind of like most things. It doesn't fix everything for everybody, but in the right situation, it can be another thing to do, another type of treatment which can be helpful.
I've had a message from Dana, by the way, that she is apparently back. So you may well find that once you've talked about movement disorder departments, that she takes up the helm. But if not, I will be here on standby.
Thanks. So about movement disorder departments. So the way neurology services are organised in the UK, and actually in most places around the world, is that all neurologists have neurological expertise, but then most neurologists have a subspecialty interest, because neurology covers such a large, part of medicine. You can't know everything about everything. So movement disorders is one of those subspecialties, and that would cover dystonia, but it also covers Parkinson's disease and tremor and Tourette's syndrome and so on. Within the neurology services are organized in a sort of hub and spoke model. And what that means is that in your local hospital, there would be a neurologist who would attend there, who might have might be a movement disorder specialist, but might not be. But then typically at the regional centre, there would be a movement disorder group. So there'll be movement disorder specialists, neurologists, and that might be where some of the specialist diagnostic stuff is done. It might be, if you have a deep brain stimulation service, that would be where that would be. There would definitely be a botulinum toxin service there, but you would probably have botulinum toxin clinics in local hospitals as well. I think, if I had multiple sclerosis, I would expect to see a multiple sclerosis specialist. Likewise, if I had dystonia, I would hope to see a movement disorder specialist. So I think it's a reasonable thing to do, to be referred to a movement disorder specialist if you have a movement disorder. And that should be something which is available to everybody. There shouldn't be a difficulty in doing that, because every regional neurology service would have a movement disorder department.
Fabulous. Thank you. Hi, everyone. I do apologise. My internet dropped out, and thank you to the amazing Victoria for just jumping straight back in there. That was a really good answer, Mark. So thank you very much for that. I'm going to move us on, just because we've got a lot of questions to get through. So I'm going to move us on and we're trying to group them together if anyone's following along, to symptoms now. We've got a lot of questions on symptoms. And the first one for you is that it's around anxiety and depression, and especially at the moment, considering that we are still within the COVID pandemic, is a real issue for many. And the question that we've been asked is anxiety and depression specifically linked to dystonia? Does one cause the other to worsen? And if so, how could someone go about breaking that cycle, please?
That's a really good question. And I think I'd like to start by answering that. I would say that I do recognize the significant stigma that's out there about mental health problems, whether that's anxiety and depression or other things. And also that the experience of many people with dystonia is that they've often been told at the beginning that their problems are due to anxiety and depression, and they've been misdiagnosed in a sense in that way. But that's a shame, both of those things, because anxiety and depression and other mental health problems are a fact of life for most people who have neurological conditions. And the reason for that is that your brain and your mind are they occupy the same organ. And so it stands to reason that if the brain has gone wrong for some reason, it might affect the way that you think and feel. And that's beyond the psychological fallout and social fallout of having a disabling medical problem. So that's why I feel very strongly that it's such a shame that these issues are often an issue of conflict, because you should be able to talk to your doctor or health professional about these sorts of problems and get help. What we know about dystonia is that if you look at large groups of people who develop dystonia and you look back at their mental health before the diagnosis, before they develop symptoms of dystonia, you find higher rates of depression and anxiety than you would expect by chance. And you also see that in lots of other neurological conditions. So you see that in Parkinson's disease as well. And so what that says to me is that something about the wiring changes that happen with that cause the movement problem probably affect the way that people feel as well. Obviously, like I said, there's another part of that, which is if you have dystonia and if it causes you pain, it causes you loss of sleep, it causes you worry about the way that you look, the way that you appear to other people, all of that can trigger anxiety and depression too. So I think what to do about it is no different really from most other causes of anxiety and depression, and that's that it's a problem that needs to be recognized. It's something which is not anything to be ashamed about. It's not your fault. It's nothing to feel guilty about. It's not because you haven't tried hard enough or you're lacking in moral fiber. It's a kind of real thing that's happening. And sometimes acknowledging that and knowing that you're supported amongst your family and people that care about you, that can be enough. But other people do need treatment, and that's where accessing services like psychology services, or some people benefit from taking medication for mood. Some people benefit from taking medication for mood and having psychology input. And that's also where charities and like Dystonia UK, I think, can be helpful, where there may be other more sort of physical things that one could help in terms of mood, like physical exercise, or whether that's yoga or Pilates or mindfulness classes, or there's all kinds of different things that might be useful. And I think part of that is learning how to live with a long-term condition and the changes that causes to your own identity and to the way that people react around you and all the rest of it. And that's, I mean, I haven't had to do that myself, luckily, but it must be incredibly hard. And so, again, I think some of that is about acknowledging that that's a real thing, that's a valid way to feel. Yeah, I think with that and with the services that are available, I think it's something which can definitely improve and can lead to an improved quality of life.
Do you find that when people say that they're suffering from depression, if they go to a doctor and say that they are suffering depression alongside their dystonia, that one is taken perhaps more seriously than the other, or that one is tried to be treated more than the other, so that, for instance, their dystonic symptoms may be coming on because of the depression? Have you heard that kind of thing?
Yeah, I mean, I think this gets back to this whole sort of state of conflict that sometimes exists, where somebody's being told, you know, if you have dystonia and you go to your GP and say I'm depressed, then they might not sort of recognize the dystonia side of things, and are maybe only interested in the depression, and maybe only interested in quite a superficial way. But I think part of it is sometimes part of it is about having to push a bit yourself. And I think that if you're confident in your own mind about the fact that I have dystonia, yes, it's affecting my mood is affected as well, this is a genuine thing, then it's about trying to find somebody who's going to help. Yeah, but that's why these early experiences that many people have, where they go to their GP with problems and they're told it's anxiety or it's depression, can be so negative, because then you're automatically in a situation of conflict and fighting, which doesn't really help you in the long term.
Thank you. I mean, I think we've probably got questions and could go on about that particular subject all night. Again, I think that's probably a separate webinar. To move on to some other symptoms, we've been asked, can vocal dystonia cause symptoms like a persistent cough?
The honest answer is possibly yes, but it's not usually the commonest. Well, it's not the commonest symptom people would experience. So most people with laryngeal or vocal cord dystonia, sometimes called laryngeal dysphonia, the main symptoms are a change in voice, either of hoarseness and pitch breaks, so the voice is sort of suddenly high and then suddenly low, or sometimes a sort of whispering, breathy voice, often which changes as well. So that's the main symptoms of having laryngeal dystonia. Those people might also have a cough, or that could happen as part of that, but it wouldn't be the only symptom. And I would think about other causes before I would think about dystonia.
Okay, brilliant. And this is an interesting question. The question is, why do spasms seem to get worse for some people living with dystonia when someone sits close to them? And I've heard a couple of our members and supporters tell me that if they see a door frame, their spasm might get worse. Or one person told me if they saw a blue cone, didn't happen on pink cones, just blue cones, they were doing a sport or something. So is there a reason that some things will set off the spasms of dystonia?
Yeah, I think there are, and the commonest thing that I would hear is being in a social situation compared to being at home. And I think that you have to think about what's happening in the body and brain when you're in a social situation, and that's there's a release of adrenaline. Doesn't mean that you're necessarily feeling anxious, but that's just your body is the volume is turned up in the body. You're more alert, you're more aware. And in that situation, if you record from the muscles of people who don't have dystonia, so people in good health, you see more muscle activation, you see more tremor, which you can actually see visibly, but there's more tremor in the body and muscles are more turned on. So if you already have dystonia, then if you go into that situation, then those things are going to happen to you as well. But because you already have dystonia, it can often very significantly worsen the spasms. And then there's another process which typically happens, which is that people then feel that their spasms are worse, because they are. But in a social situation, that can lead to worry and anxiety about what other people might be thinking, and more of your brain's attention is actually turned onto the body, and all that does is wind up the problem again. So people can get into a sort of vicious cycle in this way of worsening of symptoms in social situations. But it can also happen in other situations where your brain's just more alert, like actually going through a door. Your brain's just a bit more turned on in that situation.
Okay, interesting. I have to say that when I got told about the green cone and the pink cone, it was Gemma Stevenson, who is one of our ambassadors, who won't mind me sharing that story. Every time she saw a green cone, she had a spasm, but she could go around the pink ones absolutely fine. And I think that's one of the things that's so fascinating about dystonia, isn't it? Is when the brain is turned on like that, the effects it has on you.
Indeed.
Okay, so the next question is, why do spasms seem to get worse for some people? No, I apologize. That's not the next question. That's the last question. This is the next question. Some people find yawning can set off their cervical dystonia. And is that anything to do with the vagus nerve being activated, or is cervical dystonia the root cause?
It's a difficult one. I mean, all I would say is that people with dystonia often have specific things that make the dystonia better or worse. I mean, the commonest thing we hear about people, that makes it better is sensory tricks. So touching the face, for example, or can reduce cervical dystonia in some people. I think it's about, dystonia is a problem with motor control. And what I mean by that is it's not a problem with the strength in muscles or the basic wiring of things. In that way, it's a problem with the way the brain's controlling your muscles, and lots of those things are very situation specific. It's like you have programs. There's like a movement program that's turned on at a particular time, and I could imagine how doing particular actions might switch that program into one which is sort of less dystonic, if you see what I mean. And other things. So on the opposite of that, for example, in clinic, when I see people with cervical dystonia, when I'm assessing them, I'd always get them to walk up and down, because I know that during action, dystonia tends to get a lot worse compared to when people are sitting still. So it's not a full answer for everything, but I think there's something around that about particular programs with movement being more or less affected.
Okay. And staying on with cervical then, are facial tics associated with cervical, so neck dystonia, or is there, and if so, is there a suggested treatment?
So that's a good question. So tics are a different kind of movement disorder. So tics, as you might see in people who have Tourette syndrome, but they're actually common in other people too, are brief, repetitive, stereotyped movements, or sometimes vocalizations, which means sounds. So it might be a quick eye blink or a shrug of the shoulder, but it's done repetitively and it's not under somebody's control. So some people who have tics have what are called dystonic tics, which means that instead of being just a quick spasm, like a blink it's more of a sort of turn and then it goes away. So something like that. And it's different from dystonia, but actually often you might treat it in the same way. So botulinum toxin is quite useful actually for some of those dystonic tics, but it is a different condition.
Okay. And sticking with this kind of theme, can deeper muscles be involved in axial dystonia?
Can deeper muscles? I'm just trying to think about what that exactly means. I mean, I think the answer is lots of different muscles can be involved in dystonia. That's true, and certainly deep muscles in the neck are sometimes involved, and that's sometimes the reason why botulinum toxin injections don't work very well, because there's only a small number of muscles in the neck that are usually injected, and sometimes deeper muscles in the neck that are involved, which you can't easily get to. In terms of axial dystonia, most of the muscles it's actually a bit more simple, because the muscles are all quite superficial. So yeah, I don't know, but certainly it is true for the neck that deeper muscles can be involved, and that can be a reason why people don't get much benefit with superficial muscle treatment with botulinum toxin.
Okay, and then we'll take a couple more on sort of the symptom side, as it were, and then I think we will move on so we get a fully rounded webinar for everybody. And thank you so much for your questions, everyone. They are coming in thick and fast, and I know that Victoria is collating them all, so please don't worry if we don't get a chance to ask them. We will try and get answers. Mark, have you ever seen generalized dystonia start sporadically with no other clinical symptoms? And so generalized dystonia, FND, can you also just remind us what FND stands for those that might not know?
Okay, so that question is a good example of one of the problems in sort of in the words that we use around this. Lots of the words we use for dystonia it's talking about a sort of just trying to describe the anatomy of things. So blepharospasm means dystonia affecting the muscles around the eye. Generalized dystonia means dystonia affecting most of the muscles in the body. It doesn't actually say to you what the cause of that is. And as I talked about before, there's multiple causes of dystonia. So functional neurological disorder is a cause of dystonia. So functional neurological disorder, or FND, is a common way in which people develop neurological symptoms. And it's a complicated condition to explain because it doesn't follow the rules that we usually think about how neurological conditions work. So in functional neurological disorder, the basic wiring of everything is okay. People are trying as hard as they can, so there's no problem with their will or motivation, but they can't access or control their body in a normal way. That can lead to lots and lots of different symptoms, from weakness to seizure type episodes and so on, but it can also lead to problems with movement control like dystonia and dystonic postures. And the typical presentation of that in people with dystonia is of a fixed abnormal posture, often with a lot of pain. Now, that can happen, the commonest way in which it's triggered is in the context of another health problem. So often people with functional dystonia, it happens acutely after an injury or another illness, and sometimes after a stressful event or traumatic event. But it can just arise, without any obvious cause. So it does happen. It's not that common, but it does happen.
Okay, thank you. And is it common, our next question, is it common to have fibromyalgia with dystonia?
It's another really good question. So, and again, it's a sort of another issue around this sort of terminology. So fibromyalgia is a condition where people experience chronic pain, and people with dystonia commonly have pain, and some people more than others. Some of the pain that people with dystonia experience can be explained by just the fact that muscles are turned on all the time. And if you're sort of fighting against the muscles all the time, that can also cause pain. But then some people develop a more generalized pain. It's almost as if the whole body becomes sensitized. And that's a slightly different thing. That couldn't really be explained by just tension within particular muscles. And so that means it's likely that the brain is not functioning correctly in that way. And it's a little bit, there's a lot of overlap there with functional neurological disorder, as I just described. So we have a system that sort of kind of somehow helps us communicate with our body. It helps us move voluntarily, but it also helps us perceive what's going on in our body. And if that system goes wrong, if the volume is dialed up on it, then people can experience real and genuine pain, which is often very severe and disabling. But it's not really caused by damage within the muscles. It's caused by a problem with the way the brain is processing sensation information coming from the body. And people with dystonia can certainly get that problem as well. I mean, that might be diagnosed as a chronic pain syndrome or fibromyalgia. But yes, it can happen together.
Okay. And sort of sticking with that theme, I guess, but can dystonia cause memory problems? And the end of this question is and intrusive thoughts, and I think that goes back to perhaps what we were talking about with the anxiety and the depression.
So the answer is yes, and in different ways. So if, for example, you have dystonia which is due to a degenerative problem of the brain, like I was mentioning with Parkinson's disease, then yes, that neurological illness can affect memory too, and so people might experience memory problems. But much more commonly, I think the issue is that because symptoms are so intrusive and disruptive, so if the neck is posturing all the time or the body is posturing all the time and there's a lot of pain that's going on, that in its own right disrupts memory. And it does it by not really, it's not a dementia type of problem. It's not actually that memory itself is affected. What's affected is attention and concentration. And so that means that people can't get information in, so that they have the experience therefore of forgetting stuff all the time, and then they can't get something out either, so they can't recall things. And often that's very variable as well. So it's an important part of the kind of more global disability that can happen for some people who've got dystonia. And yeah, as part of that, some people can develop mental health problems, which can include anxiety and depression and other things as well. And in the context of that, people might experience intrusive thoughts. And that's a very clear situation where having that evaluated properly and thinking about treatment for that would be a really good idea and would hopefully help.
With the memory problems, commonly is that referred to as a fog? So I know with fibromyalgia it's an actual thing, there's fibro fog. Is that true of dystonia as well?
Yeah, I think so. So across lots and lots of neurological conditions, people experience brain fog, which is this attentional concentration difficulty associated with memory lapses. And I think it's, if you think about it, it makes sense. This all of this stuff that's happening is a big demand on your system. It's like a big drain on your battery. And if that's happening, you just don't have as many resources left over to attend with and to concentrate on and remember things with. So it does happen, which is why different types of treatment, which hopefully improve symptoms, can sometimes have a really positive effect on all of these consequences we're talking about, like pain, like mood, like cognitive problems.
Yeah. Okay, so last question then in our symptoms section is, can dystonia cause symptoms like numbness and inner itching?
So yes and no. And so the reason why I'm saying that is that it can do, but in that situation, I would often think about whether there's another problem there, which maybe the dystonia has caused. So for example, some people with neck dystonia, which is severe and long-standing, they can get wear and tear changes in the spine, and that can cause pressure on nerves, and people might get numbness and tingling down their arm. People with hand dystonia might get carpal tunnel syndrome just because of the movement that's going on all the time. So this is a good example where it can be really difficult sometimes. If you have a long-term condition, particularly one which people don't understand very well, then it's very easy for doctors to say, when you turn up with a new symptom, to say, oh, well, that's your dystonia, without necessarily thinking. Of course, it might be the dystonia, but it might be something else. So things like numbness and tingling or weakness or other new symptoms like that are things that need to be evaluated properly. The sort of inner sense of itching, again, the immediate thing I would think of with that is a condition called restless leg syndrome, which is common. It's associated with iron deficiency, but can also just happen anyway. And people tend to experience really uncomfortable crawling, abnormal sensations underneath the skin, particularly in the legs, usually in the evening and at night, and a sort of an intense urge to fidget and move the legs. And when they do that, the sensations go away briefly, but then they come back again. So that's a different condition and something that needs evaluation, and there's treatment which can help with that.
So if you are experiencing any of that, for the person that asked the question, your recommendation would be to go and see their clinical team.
Yeah, absolutely.
Brilliant. Okay, I'm conscious of the time, so we are going to move on to the treatment section, and we've got nearly as many questions here as we did in the last one, so I'll try and get through them for everybody. This is a really interesting one, actually. Have you learned anything about the treatment and management of dystonia symptoms during the last 12 months that might change management of dystonia in the future?
That's a good question. I mean, things move at a bit of a glacial pace sometimes in medicine, unfortunately, but I think I have mainly, and that's relating to people that I work with who are doing research in deep brain stimulation surgery, and developing different ways of targeting different parts of the brain to try and help people with dystonia. And that work, although it's quite new and experimental, is looking really promising. So that was something just personally to me, which made me feel positive about things, and that there might be advances in treatment, at least from that point of view. Yeah.
So other than sort of DBS technology, are there any new treatments on the horizon apart from the developments that you just mentioned, obviously?
So there are, but they're a lot of them are about the same sort of thing, just trying to do it better. For example, what deep brain stimulation is doing is just basically blocking a part of the brain from working properly, and you can actually do that with a lesion. So previously, before DBS, you would get a surgeon would go in and burn a little hole. It sounds very unpleasant, but burn a little hole in that part of the brain. You can actually do that theoretically with something called focused ultrasound. So focused ultrasound is an ultrasound, as you might have to look inside the body, but it's a different thing which can actually heat up a bit of the brain without having to open the skull. And so that's been trialed recently in tremor, where it seems to be effective. And there have been studies which have been done in Parkinson's disease, and I expect there'll be studies which are done in dystonia as well. I mean, it still is, causing a focal area of damage in the brain, putting it very bluntly. So it's not, even though you don't have to do an operation, it's still a major thing to do, and obviously could go wrong as well. But that is a development. From the botulinum toxin point of view, the things I'm aware of are mainly people who are experimenting with preparations of botulinum toxin that could last longer. And there have been some developments thinking about why it is that in some people botulinum toxin stops working, and that's probably that there's some evidence that is about resistance to the toxin. So that's another area where people are trying to think about, well, how can we detect that resistance? How could we stop it from happening? From a drug treatment point of view, there's very little, unfortunately, that's changed in terms of new drug treatment that I'm aware of. There has been quite a lot of developments in trying to, in sort of genetic technologies. And again, these things are very, often a very long way away, but I think they're going to become more of a reality. So that's where the smallish number of people who have known genetic cause of dystonia, there might be new treatments in the future there.
Okay, that's a lot to unpick, and I'm thinking of that in relation to the questions that we have had. We've had quite a few people saying that their botulinum toxin injections, which you mentioned sometimes don't work, or sort of the wear off as to how effective they can be, the effectiveness wears off. So is there anything that individuals can say or do that will help guide the injecting practitioner to the best place for that injection, do you think?
Yeah. So I think that this is a situation where you need to have a bit of confidence in talking to your team. And I know that's difficult because I know what botulinum toxin clinics are like. They're like a sort of conveyor belt sometimes, and trying to get through lots and lots of people, and there's no time to talk. But there are quite a lot of reasons why botulinum toxin injections don't work. And some of those are things which are changeable. So, for example, in some people, the dystonia pattern changes over time. And so just keeping on doing the same muscles is not going to be effective. So when it's not working, having a proper look, having the clinician look again, think about your dystonia, think about, are we injecting the right muscles? There are some people where getting at the right muscle is a bit difficult. And so that might be the skill of the injector, but it also might be just that the dystonia is difficult. So that's a situation usually where using EMG guidance, so electrical recordings from the muscle, or using ultrasound guidance can be useful. Some people, like I was saying, seem to get resistant to the toxin to some extent. And that's where, you might need to escalate the dose in that situation. And that needs to be a good conversation with your doctor, because that can sometimes go a bit wrong because people can get side effects. Sometimes there might be other things going on. So if your mood is down, if the pain is awful, you know, if other medical problems are there, then that can make the dystonia worse. So it's about having that really holistic look, I think. And in the end, sometimes botulinum toxin is just it's not a very effective treatment, like anything. It doesn't always have to work. And I think sometimes it's given, and the doctors give the impression that it's a sort of miracle thing, but it isn't. And it's certainly a good way to manage symptoms for a lot of people. It's a lot better than times when we didn't have botulinum toxin, but it's not a miracle. And that's where I think trying to get this whole holistic picture and thinking about other things that can be done, which include things which are not about doctors. So they include things around physical treatments, around sort of more exercise-based treatments, around psychological treatments, well-being treatments. Those are all relevant too.
Thank you. And have you found at all that people have had any, or what is your advice, sorry, for people who perhaps have problems swallowing after they've had DBS, just to stay on that as a related topic, because you mentioned it briefly?
After botulinum toxin, do you mean? Or yeah. You know, that happens. It's very obvious why that happens, and that it happens because some of the muscles you inject are at the front of the neck, and the botulinum toxin spreads. So it's a dose issue and it's a muscle selection issue. So the only thing you can do is to reduce the dose or change the site of injection, or both. So it's important to flag up those swallowing problems to the person who's injecting you, and to ask them what they're going to do to make it not happen, because it's possible to make it not happen. Obviously, sometimes, unfortunately, the muscle that you really want to inject is the one where it's very hard not to cause swallowing difficulties with. But it's about adjusting the dose and site of the injection. Okay.
I mean, we've had hundreds of questions, and I'm very sorry to everybody whose questions we might not have got to yet. I just want to ask, because we'll have a lot of new people that perhaps weren't on your last webinar, and I know we spoke about this, but what can you tell us? Is there any new news about the COVID vaccine and dystonia?
So the basic answer is that all the information that is available is that the COVID vaccination is as safe in people with dystonia as in anybody else. So there seems to be no particular worry about people with dystonia having the COVID vaccination. Obviously, any person who has a medical condition, if they do get some of the common side effects of vaccination, which include feeling fluey and a bit painful and so on, it's likely to hit them a bit harder than people who don't have dystonia. But I wouldn't have any concerns about the COVID vaccination and people who have dystonia. And obviously, if you have dystonia and you get severe coronavirus, having dystonia doesn't help you. So it's important for people with dystonia to have the injection, I would say.
Okay, and the very last one, just because it happens to be related, is, do you know if children under 16 are eligible for the vaccine currently?
No, not that, as far as I'm aware, no. I'm not sure whether there's any specific things for people who have specific medical conditions, for example, immune deficiency or other sorts of medical conditions like that. But as far as I'm aware, children under 16 are not currently eligible.
Okay, Mark, thank you so much. That was amazing. We've done 2 hours of these now, and I don't even think we've touched a third of the questions. So for everybody that asked questions, thank you very much. For anyone we didn't get to, we will try and find a way to get that information to you, but bear with us. But for this time, can I once again thank you, Mark, for being here. It is a delight, and we'll see if we can get another one of these organised. Thank you to my amazing team, to the tech team, Fran and Nat, to Victoria, who so lovingly jumped in and helped out when my internet dropped out, who is our Director of Operations and Development. And thank you. I know that a lot of our board and our regular supporters have been online as well. But most importantly, thank you to everybody that turned up, that listened, that asked questions. It is lovely to see you all, and hopefully we will see you on the next webinar. So thank you all very much and have a lovely evening.
Thanks, everybody. Good night.
Night night.